right. Well, good morning, everyone. Thanks for joining us today. Hope you're having a great day. Remember, no matter how your day starts, you can always say today is going to be a great day because you can always turn it around. We've got a great set of speakers here for you today. I hope that you're dealing quite well with the coronavirus, starting to get your vaccination appointments set up if you're able to yet. Hopefully everything here will be, we're in the final stage of things, and things will be turning a lot better. But until then, we are still live streaming our meetings instead of meeting in person. Those live streams will continue on the third Saturday of each month. Myself, I'm Aaron Lamb, your meeting facilitator. And we have a number of other hosts and volunteers in the organization that I would like to mention. Our main directors are Lyle LaRoche and Jean Van Vliet, who've done a fantastic job over decades in maintaining this organization. They've done a great job. Bill Manning is our videographer at our in-person meetings, and John Tassi is our webmaster and is taking care of all of our video streaming while we are meeting remotely. Steve Pendergast does a great job with the newsletter. I do hope that you both receive those in email and occasionally can go back to them. They're all for review. They're all posted on the website. The website has a great amount of information and for you guys to use out there. And Bill Lewis writes up our meeting summaries, does a fantastic job. And I encourage you to read through those if you do miss any of our meetings. And myself, as I said, as the facilitator, we've got over 900 members, and everyone is a volunteer. You can be too. Please do contact us if you have some spare hours that you could help us out. In our support to you, we have the website, as I mentioned, where you can find the newsletters and find the monthly video streaming link. And the other important thing is our hotline number. And please do call that number if you're in need of any kind of help, any information about your treatment or concerns that you might have on trying to get the best care. Our organization certainly has a huge amount of experience behind it in dealing with all sorts of treatment for prostate cancer. And as I said, we could use volunteers, especially people to help recruit and schedule the next speakers. So again, contact us through the website or that hotline number if you can help out. Now, our support group purpose is to share patient-focused experience on becoming your own case manager through informing, networking, and caring. As I said, we have a ton of experience behind us. We're not medical professionals, and anybody who does share their opinion from amongst the members of the group should not substitute for your own medical counsel. And we do need your support. Even though we're not meeting in person, we do have a number of expenses throughout the year that we need your help in paying for. Remember, donations are tax deductible. We have no medical or religious affiliations. Many companies will even match your donations that you provide. Some of our main costs are to keep our website up and running, as well as to advertise to get our word out to other men facing the same issues as the rest of us. So please do make a donation online if you can. You can do it online via PayPal or sending a check. And that address is also available on the website. Before I get to today's agenda, our next meeting is going to be with Dr. Dato. He's the Director of Medical Quality and Director of the Prostate Cancer Center as part of Genesis Health Partners. And I believe he will be giving a talk on active surveillance, and that will be on February 20th. But as for today, we've got a number of doctors here to spread a wealth of information. They are from UCSD's Department of Radiation and Medicine. Dr. Mundt, Sharabi, Seibert, Rose, and Rossi. And I'm actually going to turn it over immediately to Dr. Mundt, who actually has a much more in-depth introduction for each of our doctors. So thanks everyone for tuning in. And Dr. Mundt, please take it away.
Well, great. It's wonderful to be back. I'm sorry we're in the COVID era and it's a little different, but usually in January, I'm really pleased to be able to offer sort of updates in radiation and prostate cancer. So I'm going to share my screen. And today, what I wanted to do was, every year I sort of think of what's a good thing to do. And I thought, why don't I bring 4 interesting prostate cancer specialists to give sort of a potpourri of interesting things about radiation oncology and prostate cancer. So I was just going to spend a few minutes just getting people up to speed on just some terms and how radiation's used, but not go into too much depth. And then we were going to have the different people talk about different topics that are relevant. And each one will be about a 12-minute presentation. I wanted to make sure that we have lots of time for Q&A at the end. So we kept the presentations on the shorter side. And then the 5 of us will then be available for asking and answering, hopefully answering, all your questions about prostate cancer. So here's the group that's speaking today, Dr. Rossi, Dr. Sharabi, Dr. Rose, and Dr. Seibert, and I'll talk about each one of them in a second. But there's lots of us who aren't here. At UCSD, there's actually 10 people, 10 physicians that work in prostate cancer, and Dr. Eink has spoke, I think, with Carl a few months ago. He's expert in prostate, especially brachytherapy in prostate cancer. Dr. Urbanik works in Encinitas and at the Proton Center. Dr. Hoops, Dr. Sandhu, and Dr. Advani. And a question that I often get is, we're spread around the city and we have all these different doctors with prostate cancer, but if you walk in door 1, do you get a different opinion than, differently? And the one thing I wanted to stress is, even though you may see one doctor, we're all a group and we interact and we actually have guidelines and standards for what we do. So if you see, if you live in South Bay and you see Dr. Advani, he's going to give you the same recommendation that doctors in different locations will be. And I think that's important because it isn't like you need a second opinion from one of them to the next one. We all interact as one group. So I just want to say a few things about terminology about radiation and prostate cancer. There are 3 main pillars of treatment: surgery, medical therapy, and radiation. So you can think of surgery as, the prostatectomy, take the prostate out. There's, really cool things about robotic approaches to make surgery better and faster and safer. Medical therapy is either chemotherapy or more commonly hormone therapy, or truly anti-hormone therapy, lowering hormone levels to treat prostate cancer. And then what we're focusing on today is radiation therapy, which is either from the outside, external beam radiation, or from the inside, brachytherapy. So radiation in prostate cancer, it's not a new thing. The first patient that I could find in the literature is 1909. It's been around forever. There's 2 main different ways to treat prostate cancer. You can treat without surgery, and we call that definitive treatment because there's no surgery. and adjuvant treatment, and that's when we treat a patient after surgery. So those are the two major treatment approaches. In radiation therapy, we have two main ways as well. External beam radiation, we call it EBRT. A patient lies on a treatment couch, like the one up in the upper left, and it's a flat table, kind of hard table, which is a little annoying, but we need to keep a patient still and in the proper position. And then we can either use photons, which are X-rays, X-ray therapy, or protons, which are particle therapy. And we'll be talking about both types. But to a patient, they kind of look similar. Here's actually a proton patient. And you're on a table and the gantry moves around. The difference is basically behind the scenes. When you're getting treated with photons or X-rays, the machine is actually in the room and moves around you. When you're treated with protons or particles, actually here's the couch and we stripped away the wall, and actually what you see behind the wall is this huge multi-story machine. So you don't see that. What you see is basically just the couch and this area up here. But you can see the guy standing here. This is a huge piece of equipment. When we talk about external beam radiation, we talk about something called fractionation. And fractionation is just how many treatments do you get? We do things conventionally. You give a small dose of radiation every day for a long period of time, 8 to 8.5 weeks. And that was a very common way to do things up to about 5 years ago. And what's been happening over the last number of years is that we've been shortening the treatment, so hypofractionation. And it's important to realize that the shorter treatment isn't less dose. You actually give more dose per day, but you shorten the number of doses that you get. So some patients, when I remember when this first came out, they were worried that we were giving less treatment, but we actually just treat it in fewer days, but more per day. It's, if you think of it like a pill in a pharmacy, the pill just has more drug in it and you're taking less of the pills, but you're getting actually the same amount of treatment. But the hope is it can actually not only be more convenient, but it can be more effective. If you get a really short treatment, 1 week or less, we call that SBRT, or stereotactic body radiotherapy. And that's a large amount of radiation over a very short period of time. So that's important. When you talk to doctors, you may get a different recommendation for the number of treatments. And that used to cause a lot of havoc in our waiting room when patients would talk to each other, and one patient was treated with this one way and one was less, and it became, but each way is, needs to be tailored to the patient. Things would be good for one patient, might not be good for another patient. Brachytherapy is internal radiation. And internal radiation is when we implant radiation, radioactive pellets into the prostate. Here's an example of that. Or you can do it temporarily by putting needles into the prostate and giving treatment over a short period of time. So we call those two, they're a little different. They're either a permanent or a temporary implant. When it's permanent, it has the name low dose rate. It's giving the dose over a very slow, over a number of days to weeks, where the temporary one gives a high amount of radiation very quickly, but the amount of treatment is the same between the two. So let's talk a little bit about the process of radiation. When you go through radiation, you first, like any doctor's appointment, you see a physician. So you do a consultation. And that's where we talk about, we talk about the treatment, we give our recommendations, the pros and cons, and we actually, like a surgeon, get a consent form and talk about, the risks and benefits. Then we do a simulation. And the simulation uses a scan. A lot of patients often ask, well, why do I need another scan? I had a scan just a few weeks ago. And the reason is it's not a diagnostic scan. It's actually a scan that we use to plan and map out what we're going to do. We put you on the table, make a mobilization, get an image of you and your prostate, and then use that to target the radiation on the computer, which then is used every day on the, when you come in for treatment. The next step is that we have to do a treatment plan. And that's when we sit on at the computer and we outline where the prostate is, where the bladder and the rectum are, and we plan out how the radiation is going to be delivered to you. Everyone's body is differently. Everyone's a different size and shape. And so we have to customize it to the patient. And that's what's going on between your visit when you had your simulation and your first treatment. We have some homework to do to make sure that this is a very good plan and it's very safe. So that takes about a week to 2 weeks to do that. And then finally, you start getting treated. So we position you on the table, and then we take images before and make adjustments. You see a doctor at least once a week. If you're having no problems, it's once a week. And we check in with you and see how things are going. We don't do PSA tests and things during treatment because it's too soon. It'd be like opening the oven door when you're, have something cooking inside. So we don't like to open things and, see how things are going. We want to let the treatment work. And then a few weeks to months later, do the first PSA. So the treatment being on then the treatment table, and we take images before to line patients up, and then we see them during treatment and make sure the treatment is working. And that if there's any side effects, we treat those side effects. So as I talked about, there's different kinds of approaches. Definitive RT, the most common is external beam. So for definitive RT, you can either have photons or proton therapy, and then you can either have it conventionally or hypofractionated or even just a week of treatment. So there's lots of different ways to do definitive RT. Brachytherapy could be part of it. It could be low dose rate or high dose rate. It could be combined with external beam and brachytherapy with either photons or protons, or, so it becomes this huge number of options. So we often spend a lot of our time in a visit talking about all these different options. And usually, depending on the PSA and the level of the Gleason score, we often combine it with Lupron and other anti-hormone therapy. For adjuvant RT, we can do it again with either photons or protons, but we usually only conventionally fractionate it. Most people don't hypofractionate treatment after surgery. There's no brachytherapy because there's nothing to put the seeds into because the prostate's gone. We don't do things like SBRT or hypofractionation. And we can't combine it with brachytherapy because, again, there's no prostate to do. There's two kinds of adjuvant therapy, and they have a terrible word, salvage RT. It's when you do adjuvant RT in patients with a rising PSA. Salvage RT may be combined with hormone therapy, again, depending on certain factors with the patient. So this is just an example of a word that sounds terrible to a patient, but it's just meaning you had surgery and now the PSA starts to climb again. Can we jump in and fix things all over again? And often we can. So let's now move on to the different presenters. And given my bad internet connection here, I'm going to introduce all four of them right now. And then we will then go into their different presentations. Brent Rose is an assistant professor in my department. He's has a joint appointment in the Department of Urology, which is very prestigious for a radiation oncologist. He did his training at Harvard University, of course, on the East Coast. And he's well-funded researcher. He has a Department of Defense grant looking at active surveillance in a very special group of patients, African-American men who it's often aren't treated with active surveillance because of worries about them being at high risk. He's published extensively on a number of things, including finasteride in patients with prostate cancer and the cognitive effects of hormone therapy. So that's Brent. And one nice thing is he started recently a multidisciplinary high-risk clinic with Ronna McKay, who's a medical oncologist, Kelly Parson, who is a surgeon, and Brent, and they see patients all together in one setting, in one clinic, which is really exciting. Tyler Seibert is an assistant professor in my department. He has, to outdo Brent, he has joint appointments in both radiology and in bioengineering. He did his training with us at UCSD, and his research is looking at novel imaging approaches in prostate cancer and also genetic risk of prostate cancer. He's funded by the NIH to explore the use of whole body MRI in patients with prostate cancer. And I know a number of men in this organization have gone through his clinical trial of exploring the use of that in their cases. Andrew Sharabi is a physician scientist. So unlike the other doctors, he has a PhD as well as his MD. He did his training at Johns Hopkins University in Baltimore. And his research is on the interactions of radiation in the immune system and how you can harness those effects to improve treatment. His PhD is in immunology, and it's an exciting area in cancer, combining treatments with the immune therapies. He has multiple large National Institute of Health grants focused on immunotherapy. And then finally, Carl Rossi. Many of you know him well. He's a professor in our department. He did his training at Loma Linda University. He is an internationally known expert in the treatment of prostate cancer with proton therapy. And I often joke that people often say they have the most experience in something or other. I think Carl can truly claim the most experience in proton therapy. He treated the very first patient when he was in his training at Loma Linda in 1990 with prostate cancer, and that's all he's done ever since. So, I mean, if anyone has treated a prostate cancer with proton, I think he's the guy. So it's a very exciting thing to have him with us here, in our department and here in San Diego. And I think that brings the end. So why don't I switch? Why don't we start, how about with Andrew, Dr. Sharabi? And so I will unshare.
Certainly. Well, thank you, AJ, for that wonderful introduction and overview to radiation. Can you all hear me well? Can you see my slides?
Yes, thank you.
Excellent. Well, thanks, everyone. Today I'd like to talk about radiation therapy for a new setting of disease, which we call oligometastatic. You may have heard about, metastatic disease, but there's a new term called oligometastatic disease. And what does that mean? And it's really a new paradigm. And it also, I'll touch on some possibilities to combine with immunotherapy, which is also a new treatment for cancer that is coming out. So really an overview, I'm going to be talking about the definition, what does oligometastatic disease mean? We'll be going over some of the clinical trials. I want to show you guys some of the recent randomized trials and data to support the use of this SBRT, and then highlight some of the research opportunities and trials that are available at UCSD involving radiation and immunotherapy. So what does this oligometastatic disease mean? Well, it really refers to patients with only a few sites of metastatic disease. And so, instead of, some patients may have widespread, for example, bone metastasis. Some other patients may only have a few sites. And so the concept is that maybe there's a difference between those groups. And this was really coined by Weisselbaum back in 1995 in this JCO paper, Journal of Clinical Oncology. And they said, well, maybe in these patients where they only have a few sites of metastatic disease, maybe going after them and treating them may improve outcomes specifically. And so, and that's really led to this state and concept of what it means. And oligo means few. So it means few metastases. And that's what we're really focusing on here. So these are some of the definitions. A broad definition, a lot of the trials have used 1 to 5 sites of metastatic disease total throughout the body, okay? Other trials have been a little more conservative and tighter and saying, well, maybe it's just 1 to 3 sites of metastatic disease. What defines few? I think that's something that's evolving, but there's a lot of these terms going around. For example, if you only have a few sites that are growing, maybe other sites are treated, but only a few are growing, maybe that's oligoprogression. Or oligo recurrence or what have you. So it's a really interesting evolving area. And I think there's a fair amount of data now for us to understand this in prostate cancer. So what does this mean systemically? Looking at the scans, right? Here's a bone scan and you see widely metastatic disease. This is unfortunate, right? Disease throughout the bones. But in some patients, and we see this quite commonly, the patients only have a few sites, okay? For example, this, a spinal lesion here, okay? So these are very different clinical presentations, and maybe they should be managed differently, not just with hormone therapy for everybody. Okay, so how can we look at that? Putting this in the graphic form, you say, well, I like using this iceberg, the oligometastatic state. Well, some people say, oh, well, the first metastasis, maybe that's just the tip of the iceberg, right? And so, is that, and there's more beyond that. Well, I don't necessarily like to look at it that way, but it's possible. Let's say this is a different iceberg. Okay, here you have, for example, you see 2 big metastases, but maybe unfortunately throughout the body there could be these other kind of smaller scattered sites. That's one scenario, but it is possible that perhaps, maybe you have clear sailing, that those 2 sites that you see, maybe that's really the only metastases that are present throughout your body. It's possible, and so additional imaging and tests can help us determine that. But you can see that there are really important differences here. So, I think AJ gave a phenomenal overview of radiation, but there's really been remarkable advances in radiation over the recent years, and they've continued to advance. So tremendous advances in technology, the image guidance of our radiation, and in fact, in some of our machines, we're going beyond millimeter, we're on the micron accuracy, sub-millimeter accuracy for setup, which is really remarkable. It's entirely non-invasive. You sit on the table. There's no, there's no needles. It's non-invasive, and it can be delivered to any area of the body. It's literally any area of the body we can treat now, and in the majority of cases has very minimal side effects. And we do SBRT in 1 to 5 treatments total. And so it's really a quite futuristic technology when you think about it. So here's some examples. These are complex treatment plans. Okay, but this is examples of treating throughout the body. So here's the lung. Okay, here's the beams as they go around. This is the dose. See how tight the dose is? This is the only area that's really receiving any real dose of radiation. Very tight. We use millimeter margins here. Here's in the liver, treating a liver here, and of course we can treat the bone. We can treat anywhere. And look at how tight the radiation dose is, how it falls off and dissipates so rapidly, and that's because of the technology. Of course, we can treat the prostate as well. So, I really think this is a fundamental change in our tool that we can treat cancer with. And so, what's the data to support using SBRT, stereotactic body radiation therapy? What's the data to support that in prostate cancer? So let's go over some of those. So these are high-profile publications, and these may be, I think, seminal studies going forward in the future. So here's in the Lancet, okay? This was published in 2019, and this was called the SABR-COMET study. They also call SBRT, also sometimes called SABR, but I like SBRT. And it's titled Stereotactic Radiation versus Standard of Care in Patients with Oligometastatic Cancers. So randomized phase 2 trial. They looked at any site of disease, and again, the oligometastatic division is less than 5 metastases, okay? And they randomized the patients either to observation, okay, or potential standard of care, okay, whatever that may be, whatever another treating physician thought was a standard of care for that, versus using this SBRT, the experimental approach, all right? And their primary outcome was to look at survival. They wanted to see if treating the single sites could impact outcomes. And in fact, it was quite remarkable. It did. They had 99 patients enrolled. They looked over 25 months of median follow-up. And here's the progression-free survival in the SBRT group. Okay, you can see it was higher than the control group. And then quite remarkably, looking at the overall survival, OS, overall survival of these patients in the SBRT group, it was also higher, 41 months in the SBRT group versus 28 months in the control group. So this is quite remarkable data, and I think it has got some significant attention from other providers because we're improving outcomes by targeting the sites with SBRT. So this trial involved many different sites of disease. There were a number of prostate cancer patients on this trial, and many were in the radiation arm. But nevertheless, I think it's very important data as we move forward. Here's another study, and this is specifically in prostate cancer patients only. And this was in Journal of Clinical Oncology, 2018, so-called STOMP trial, surveillance or metastasis-directed therapy. So directing therapy at the metastasis, local therapy like SBRT. And this was also prospective randomized phase 2 trial, okay? And they took the patients with oligometastasis, randomized them to radiotherapy, okay, focused radiation. In some cases, they could do surgery. That's a lot harder for bone metastasis. You don't want to cut out part of the bone. But, and then they looked at active surveillance. 62 patients were enrolled. They were eligible if they had a biochemical recurrence after primary treatment and with curative intent. And again, here's the definition, 1 to 3 sites. So it's not everyone, it's this, again, this oligometastatic disease. And they had this interesting endpoint too, which is androgen deprivation therapy-free survival. We know hormone therapy has horrible toxicity, horrible side effects, and we want to try to prevent the need to use it as long as we can. It's certainly a very effective therapy, but if we can limit its use and maintain outcomes, that would be nice. This was the dose in 3 fractions. So again, 3 treatments total to complete this. And here's the outcomes, intent to treat versus a per protocol. Here's the MDT or metastasis-directed therapy, which the majority of the case was SBRT, okay? And their conclusion was that hormone therapy-free survival was longer with metastasis-directed therapy versus surveillance alone, suggesting this is, and they've opened this up now into phase 3 trials. These are the standard of care trials, which can change the standard of care. And so again, ADT for 21 months in the SBRT group versus 13 months in the control group. And the quality of life was similar, and there's really, SBRT is very well tolerated. The question I ask all my patients after SBRT, do you notice any difference post-treatment? And the vast majority say no. A little bit of tiredness, potentially a little bit of local pain that goes away, but it is very well tolerated. So another trial, again, adding to this, is called the Oriole. Okay, this is out of Baltimore, Johns Hopkins, some of my colleagues that I used to work with and train with. This is a phase 2 randomized clinical trial, very similar. Their objective was to determine if stereotactic body radiation therapy improves outcomes in men with oligometastatic disease. 54 patients, okay, with 1 to 3 metastases, and they hadn't received ADT within 6 months, or they only had a total of 3 years for their curative therapy. They were randomized, they ran a randomized study, 2 to 1, to receive SBRT versus observation. This was published in JAMA Oncology just last year in March. So what did this show? Well, here we showed, again, improvement in SBRT and biochemical progression-free survival compared to observation. It was quite remarkable. And this was interesting, distant metastasis-free survival. So is it possible that treating the metastasis may help prevent other metastases from growing and developing? And that's an interesting area too. And this is some evidence to support that. Without any untreated lesions, when they treated them all, the patients had improved distant metastasis-free survival. So again, the progression at 6 months was 19% in the SBRT group versus 61% with observation. So this is a lot of data to support this. So lastly, in the last few minutes, just want to highlight some research opportunities, some clinical trials at UCSD with immunotherapy and SBRT. And how does this work, the radiation combined with immunotherapy? Well, this is what we demonstrated at Hopkins, that by using radiation, you can destroy the tumor cells, and it releases all these targets for the immune system. So the immune system takes up these pieces of the tumor, goes to the lymph node, and generates immune responses against the tumor. And we showed each of these steps quite clearly. So putting this together, here's this abscopal effect, which is also turned by, maybe if we treat one of the sites, okay, these are metastatic disease, here's the immunotherapy. We treat one of the sites, maybe that will help the other sites shrink down, help the immunotherapy work. Another question is, can we just treat them all? Let's say you have 3 sites of disease. Why don't we just treat them all with SBRT? And again, the control rates of these local sites that we treat with SBRT is over 90%. So I think these are 2 very interesting paradigms going forward. This is one of the largest randomized trials, phase 3, using immunotherapy combined with radiation in prostate cancer. And they did 1 dose, 8 gray, to a single bone-directed metastasis. This was a very large study. This was double-blind, placebo-controlled, using one immunotherapy drug called ipilimumab. Here again, improved overall survival. This was in kind of a subset of the group, so not everyone. The trial itself barely didn't meet its endpoint, but I would certainly rather be on this arm than the other control arm. I have a large study of SBRT. I personally have a large randomized phase 2 clinical trial that's open. We treat 1 to 3 sites. We have 115 patients enrolled. We've recruited a great number of patients. Again, randomized SBRT to immunotherapy. Just want to highlight a few examples of some patients that we've treated here in a lot of different types of tumors. Here's a metastasis. We treated it with the SBRT. He had concurrent immunotherapy, and this patient had a remarkable response. Here's another patient on a PET scan, multiple sites of disease. We treated 1 with SBRT. Okay, this was a rib lesion, and this patient went on to have a remarkable complete response. Now, this does not happen for everyone. These are really, select patients out of the trial. Overall, this type of complete response is extremely rare. Okay, so I just want to make that clear. But we do see it in rare cases. And so I think we need to learn more about that. So, for my laboratory and our group, it's really this concept of taking patient information, and research on patients, doing analysis on tissues that come back into my research lab. We can do focused radiation exactly like we do for patients. We can do these in animal models. Give SBRT to the mice. Here you can see the bone. You can see remarkable responses of radiation immunotherapy. We bring those back to the patient from the research lab back to the patient to try to help and improve outcomes for patients with cancer. So in summary, oligometastatic disease, it's really an established state now, but the criterion are strict. It's not everyone. Really a conservative definition is if you only have 1 to 3 metastatic sites. The data is a little less clear if you have more. But 3 randomized trials have demonstrated level 1 evidence to benefit survival if we use SBRT to treat that. We have a number of open trials at UCSD using immunotherapy. Of course, my laboratory and our radiation medicine core facility really has new technology and equipment to study this on the research slide and translate it back into patients. Just want to thank really our entire radiation oncology team. We have a phenomenal team here, and Dr. Mundt. I just want to thank him again for support and wonderful leadership, and also my laboratory. So thank you all.
Hello, everybody. Good morning. My name is Tyler Seibert, as Dr. Mundt said, and I'll be talking about some of the opportunities we have for research and advancing prostate cancer treatment and management and detection with imaging, and a little bit about genetics as well. And I'll be focusing on a new clinical trial that just opened. So mostly I will be directing these comments toward high-risk localized prostate cancer. And the treatment for that, there are a few options which were covered already. Probably the one with most clinical trials and most evidence is radiation therapy combined with ADT, which is androgen deprivation therapy, and also known as hormone therapy. And the question is, can we do better? So patients during and after treatment almost always ask, I think literally every patient asked me at some point, Doc, is it working? Is the treatment working? And the physicians are always asking ourselves, which patients need maybe a higher radiation dose, and which patients should also get more aggressive drugs like abiraterone, apalutamide, enzalutamide. They're available, but they add side effects. So we don't want to give them to everybody, but there may be some patients who aren't going to be cured with just the standard treatment alone, and we'd like to know who they are so that we could offer more effective treatments. So to do that, we really need to know how to evaluate the treatment response. And as Dr. Mundt already explained, what we usually do is check the PSA, maybe 3 to 6 months after radiation, and then every 6 months after that. But it's pretty hard to interpret PSA during and shortly after ADT. The hormone therapy lowers the PSA, and that may not, it may hide or mask what's going on with the radiation, for example. Can we see if the cancer is getting smaller early on? That's what we would like to do. And I would say, well, let's think about how did we see it in the first place? The best imaging for new diagnosis of prostate cancer is multiparametric MRI. And the most important part of multiparametric MRI is diffusion MRI. So we can weight MRI scans to measure how water molecules are moving. And this gives us a non-invasive peek into microscopic tissue structure. So just like ink diffusing in a glass of water, you can have water molecules in your body that can diffuse around during the MRI scan. And ADC is the number you're trying to get with this diffusion MRI in a standard scan. You're looking for the apparent diffusion coefficient. How fast are the molecules diffusing? Water trapped in cancer cells diffuses more slowly, and so lower ADC is seen in tumors. And these on the right, this is what the ADC maps look like. This is for 3 different patients, 1, 2, 3. This is what the radiologist is looking like. They're looking for dark spots, but it gets complicated, as you can imagine. And what about treatment response? So this is how we found the cancer with the ADC. What about looking at things as after treatment? And it gets complicated because ADT has multiple effects on prostate and on prostate tumors. There's death of endothelial cells, meaning some of the cells that are part of the prostate. There's scarring, fibrosis. There's atrophy and compression, meaning shrinking and squishing of the gland. And there's dehydration. And all of those are going to impact how diffusion is happening inside the prostate and the tumor. If you add radiation therapy and all the cell death it causes, which we want it to do, the imaging gets it gets even more complex. So where does that leave us? Can we assess treatment response in the prostate with imaging? Well, we tried with ADC. There have been a couple of small studies that showed that maybe there's something there. It's promising, but certainly weren't definitive answers. There was another study though that was small, looking at radiation, and ADC went in the wrong, or sorry, with the ADT, and ADC went in the wrong direction after the hormone therapy. So there's more going on here than ADC can account for, and you need a more advanced diffusion model, and I'll explain a little bit more detail. So free diffusion, we already talked about. Free water, ADC works great. You have one number that describes how diffusion is happening. But in the same part of the body, you also have the water that's inside the cells. And that intracellular water, or restricted diffusion, is going to change when you treat. You treat the cancer and the cells die, and then there's decreased restricted diffusion. There's less water stuck in there, and ADC goes up. So that's what we're looking for. However, you also have water that's around the cells, and it can't move around freely either because it's got to kind of get around cells as it's going through. We call that hindered diffusion outside of the cells. And the effect of radiation and hormone therapy is the wrong direction. So the ADC will actually go down with treatment because you're causing more restriction in this outside of the cells space. So what can we do? If we want to, what we care about is what happens with cells and if cells are dying. So we need to focus on that. ADC can't do it. But at UC San Diego, we've developed a new technique called RSI, restriction spectrum imaging. And that is able to look more closely at the water that's inside cells. So restricted intracellular water, and it's correlated with tissue cellularity, which like tumors, more cells, and cancer grade. So this is an example here. This is a data that we published that as the Gleason score goes up, meaning the grade goes up, then the RSI cellularity indicators also go up. And if you're just looking at how to detect cancer in the prostate, RSI, even aside from treatment, just before treatment, it's better than ADC. So this the curve that's on top wins in this analysis, and this green one of RSI is better than ADC even before treatment. So here's 3 patient examples. This is patient A, patient B, and patient C. This is a T2 weighted MRI. It's a little easier to see what's going on here, but anyway, this is the prostate. And you can see a little bit of rectum here, and this is the front of the patient. So there's this spot here, And the radiologist said, well, it looks dark there compared to the rest of this white band that's usually around. That's the peripheral zone of the prostate. And it looks dark on ADC. That's very likely cancer. So they said, very likely cancer. What does RSI show? Nothing there. Nothing in color here. And what happened when the patient had a biopsy? We had 2 biopsies on this patient. There's no cancer. So this was a false positive. Now on this one, the radiologist said, and this was a good pickup actually, little tiny bit of dark spot here on ADC, but that's really ambiguous, maybe 12 to 15% chance of cancer. Biopsy was much more consistent with what we see on RSI, this bright red spot. Sure enough, this is high risk prostate cancer that's already spreading outside of the gland. Then we have this third patient, patient C. If you look there, we're looking for a dark spot, and the radiologist said, well, maybe it's kind of dark here. Again, 12 to 15% chance of cancer. RSI, blazing hot, and this is a high-grade prostate cancer. A patient had a prostatectomy, and there was high-grade cancer there. So that's before treatment. Now, what about after treatment? This is a different color scale. We have 2 patients here, patient A and patient B, before treatment. And then we give them hormone therapy and scan them again. And you see that it looks like maybe things are getting better. The bright yellow stuff is going away. And then we scan them again after radiation, and even better. So based on the theory and that I've been talking about, and a couple of examples, and we had a couple of others, decided to run a clinical trial where we test this more rigorously. And that we just opened. So we haven't quite enrolled the first patient, so it could be you. Primary question is the change within the tumor on RSI associated with what happens long-term? Can we identify patients who are not going to be cured, and then potentially we would be able to change their therapy earlier and do something about that? Who's eligible to participate? High risk localized prostate cancer if you're getting radiation and hormone therapy, ADT. So high risk localized means you have either a high PSA or there's local spread outside the prostate, but this is before surgery, so that's kind of hard to tell. But if the MRI, for example, shows that it's in the seminal vesicles, or if the Gleason score is high, meaning 8, 9, or 10. But no lymph nodes involved. So on imaging, we don't see any lymph nodes that look very suspicious, and there are no metastases like in the bones. And no prior treatment, no other cancer, no hip prosthesis. It makes the imaging a little harder to interpret. That's the trial. So logistics, you consent to the trial, you get an MRI, then you start your hormone therapy, you get another MRI, you start your radiation, and you get a third MRI right at the end of radiation within about a month. You can do external beam with photons or protons, doesn't matter. And that's the study. And then we follow what happens long-term, and we look back and we see if the imaging would have told us what was going to happen long-term. The scans, you're in the scanner for less than 20 minutes for a research scan, approximately. There's no IV contrast, and there's no cost to the patient or insurance for research scans. If you have a clinical scan, we just add it on. It adds a couple of minutes, and there's no additional cost beyond your clinical scan. So why the DNA title slide? Just quickly, patients also ask, Doc, how did I get this? And the answer is it's mostly genetics, but maybe we can use that to our advantage for future patients. So we've developed what we call a polygenic hazard score. It's a genetic test. It's predictive of the age of onset of aggressive prostate cancer to guide decisions of whom do we screen and at what age do we start screening those men. So we can find it before it becomes an aggressive high-risk prostate cancer. We've already developed and tested this now in over 100,000 men from an international consortium, and it works really well. So this is the red curve is like a high risk, 99th percentile of genetic risk versus 95th and onward. And you see that between age and 50 and 70, that your chance of getting in these solid lines are clinically significant or aggressive disease, it just skyrockets if you're high risk, whereas your low risk genetics, very low, probably don't even need to be screened. So we tested that then in a multi-ethnic data set, multiracial, multi-ethnic of about 80,000 men, but still mostly European ancestry, and showed that it was associated with death from prostate cancer. But here's the caveat, mostly European. So it works really well. Higher number of HR hazard ratio means better performance in this context. Europeans working really well. Asian, almost as good for men of Asian ancestry. And for African, it still works better than one is working, but it's not nearly as good as the others. So we went back and tried to look just in the men that we had that were of African ancestry. We found a few markers that improved performance in that group, and we're getting better, but we need more data. So help us make it better. We're collecting data. You just spit into a tube. That's it. We take your name off of it, send it to the company for processing, who can participate. Anybody who's on our prostate cancer imaging trial, and anyone of non-European ancestry, even if you're not on the imaging trial, because we need more data to do people that aren't from Europe. If we had more funding, we would include everybody. So if you have ideas for funding, send them my way. And if you want to participate, we have email addresses there. They're here at the bottom left corner. And I'd like to thank my collaborators and the funding sources, in particular, the Prostate Cancer Foundation and Astra, who funded the clinical trial. Thank you.
Thanks, everybody. Can everyone hear me okay? See
Yes.
the slides? Excellent. All right. Well, thank you so much for having me, folks. I love coming to this meeting. We come every year, at least once, and hopefully a couple times. Such a great group because everyone is so engaged and so interested in really understanding their cancer, their treatment options, and what's coming up in the future. What can we be doing better? Which is really exciting for us. It really kind of motivates us to try to push the envelope. How can we be doing things better? So today I'm going to talk about an idea that we've actually had for the past at least 10 years in the department. We've been studying this, thinking about how we can do it better, but we've never really been able to actually do it. And that was mostly because of limitations in technology. The technology just wasn't there. The concept was there, the technology wasn't until now. So that's why we're really excited about this as an idea. We call it adaptive radiotherapy for prostate cancer. So before we get into what exactly it is, I just want to go over a little bit of anatomy and make sure that we're all on the same page in what we're looking at here. So this is an MRI, two different views. The one on the right is the one that we'll start with. This is, imagine that you're sitting on a couch looking forward. So if you can see my cursor, this would be your stomach and this would be your backside. You can see right here is your bladder. That's where the urine is stored when you feel like you have to pee. It's because your bladder is getting full. Behind here is your rectum. This is where the stool would go. And then this is the penis in front. And you can see the prostate sits right in the middle of those three organs. So this is really precious territory. We want to be as precise as possible because we don't want radiation going to these other organs we want to limit that as much as we can. On the left is another image. This is more like you're laying on your back on a couch looking straight up at the sky. So again, the top would be your belly. This would be your backside. You see the bladder, the prostate, and the rectum. So all these things are very, very close to each other. Now, in the old days, we couldn't really see where the prostate was on any given day. We knew it was in there somewhere, so we would just do a beam from one side, a beam from the other, one from the back, one from the front, and just create this box right in the middle of the pelvis. And we knew the prostate was in there because it had to be, but so was the bladder, so was the rectum, so was everything, you know? So we weren't missing, but our fields were so big that we're giving a lot of radiation to the bladder, a lot to the rectum. So we're getting a lot of side effects. Not only that, we were limited to the amount of radiation that we could actually give to the prostate because the rectum and the bladder could only take so much. So we weren't able to cure cancers as well because we couldn't drive that radiation dose to the cancer like we wanted to. So that's the old days. We made a lot of improvements since then. These days, we usually treat with more modern techniques, whether that's rapid arc or proton therapy or all these different modern techniques, which are much, much better, much more precise. And you can see on this scan here, this is what the radiation dose distribution, this is kind of going down to the higher dose. So, but you can see that the radiation, which is sort of the green and blue, is really centered right around the prostate, much, much less radiation going to the bladder, much less going to the radiation. So this is what we're doing now. It works very well. We're allowed to bring the radiation dose up to a much higher level so we can control cancers better. Our toxicity rates have dropped considerably. We don't see a lot of the side effects from the rectum and the bladder, but we do still see some. And we want to get better. We want to make sure that we're getting better and better, and we're giving you guys the best chance to cure the cancer and also to live a really good life without side effects afterwards. So how can we do that? We're already doing pretty good. We can deposit the dose exactly where we want it to go. We know exactly where your prostate is every day and how full your bladder and rectum are. But even with that, we're still intentionally targeting the bottom of your bladder, that's in the radiation field, and the front of the rectum. We're doing that on purpose. We don't have to do that, but we're doing that because we know that on any given day, your prostate might not be in exactly the same spot. And that's because your bladder could be a little bit bigger one day, your rectum could be a little bit fuller. And I'll show you a few pictures of that. So this is actually a patient that's on treatment right now. So this is a normal scan that we see. These are the scans that we do every day before your treatments, right? So on the left, you can see that the bladder is nice and big and full of urine. That's kind of how we like it. The rectum is nice and empty, and the prostate, this isn't a great image of the prostate. You can see it better on other images, but it's where it's supposed to be. So we're happy about this scan. But then the next day he comes in with the scan on the right. The patient feels like the rectum is empty, feels like the bladder is full. He doesn't know that it's not exactly how we want it to be, because you kind of can't really feel those things. But we get this scan and we see it doesn't look like what we wanted it to look like. The bladder is about half as full as it was the first time. And you can see that the rectum is quite a bit bigger because there's a big gas bubble in the rectum. Again, this is totally normal. Gas passes through all the time. Sometimes you can feel it, sometimes you can't. But we can see it and affects how precise we can be with the radiation. So this is the same patient, but this is just the other image where you're laying on your back. So again, on the right is what we want it to look like, where your prostate's sitting right here and your rectum sitting right here. But on the left is how our patient came on one day with a big gas bubble just filling the rectum. And you can see that it's also pushing the prostate forward. So let's imagine a couple things. What happens if we had planned our radiation based on what the prostate looked like on this day, and then gave that exact same plan to the prostate on the next day? You can see that the radiation by this red circle would actually be missing the back of that prostate. We can't have that. We can't be missing, because that means we're not curing the cancer. So we can't miss. So we never do this. If we see this on our scans, we say, no, I'm sorry, coming off the table, we're going to do some adjustments and things like that. But we don't find ourselves in this scenario as often, because we usually make a bigger target, knowing that there's going to be some variability. We call that a planning margin. We make the target bigger than it is on that first day, because we know there's variability. But there's cost to the bigger target as well. So in this case, with our bigger target, sure, we're getting all of the prostate here, only a little bit of the rectum's in the radiation field. That's a very acceptable plan. We like that. That looks good. But then when they come in with the big gas bubble, now the rectum is, half of the rectum's in the radiation field. We don't want that. That's too much. So in order to not miss, we do have to make the fields a little bit bigger. And this is an example case. We actually, for this patient, we had him come off the table, have a bowel movement, pass that gas. So there are a lot of things that we can do to make it better and to be more precise. And there are various things like we can give gas X, and they can use rectal balloons or tubes and things like that to vent the gas. But this is a very, very common scenario where there's just a little bit of gas and the anatomy changes, the prostate's being pushed forward or it's being pushed back because the internal organs just aren't in the exact same positions that they used to be. And just another little schematic. This is actually one that Dr. Mundt made, so I'm stealing it from him. So thank you, AJ. But just so you can see, on the left, your prostate is here, and our radiation field is just a little bit bigger than the prostate, knowing that it can move. But again, if your rectum is very big, it's going to be pushed out of that radiation field. And then so we have to get you off the table and do some adjustments and things along those lines. But really, the limitation is that the reason that we're having this problem is because we have to give the exact same radiation plan every single day. It doesn't matter how full your rectum is or how empty your bladder is. The radiation plan looks exactly the same every single day. And again, we can do things. We can get you off the table, drink some more water, fill the bladder, have you pass gas or some things along those lines. But the radiation is going to look exactly the same regardless. And there's reasons for that. And the main reason is it was just too hard to change the plan from day to day. It took the physician to come draw out exactly where the target has moved to. You'd have to get our dosimetrists and physicists to create an entirely new plan. That takes days. There had to be quality assurance steps to make sure that it was a deliverable plan, that it was safe. So that process would take days to weeks. And by that time, the prostate has moved back. So you couldn't do that every day between these treatments because it was just happening too fast. There was really no way to do it. So we did all this fun research and we said, oh, if only we could adapt day to day, we'd be doing so much better. And there's an infinite number of publications about how good it could be if we could change the plan from day to day, but we could never change the plan from day to day. It just couldn't happen until now. So through some of the work that our department has done and lots of departments throughout the country and variant engineers themselves, they've actually created a new platform they call Ethos. It looks very similar to our Halcyon machine, so some of you might recognize the machine itself. But it's actually the software and some of the hardware in this machine is so much more sophisticated than what it used to be. They're using artificial intelligence, machine learning to image the target, see exactly where it's moved, how full your rectum is, how full your bladder is at any given day. And they're adapting the targets and then really, really quickly creating a new radiation plan. And that wasn't even possible except for some of the work that from our physics department, like Kevin Moore and a few others have figured out ways to make it much, much faster to calculate these plans, knowing what the patient's anatomies have looked like over the last 1,000 patients we've treated. So they have almost a sort of a store of plans that can help inform how to create and how to change the plan given day to day. So we're really excited about this. It's actually, correct me if I'm wrong, Dr. Mundt, but I believe that actually next month we should be starting to put the machine in. You know, it is kind of a process to get a new machine. There's a lot of quality assurance and a lot of steps. I see you've unmuted yourself, so maybe correct me on that.
February 8th.
February 8th. Okay, great. So before the pandemic, we were going to be the first site to get the Ethos machine, but of course things changed. So I'm not sure if we're still the first or if we're just one of the first, but we're definitely one of a small number of centers that will have this. Dr. Munt, maybe you could chime in there.
Yeah, it says there's a handful.
Handful now, yeah. We always like to be the first. So we're, you know, if it wasn't for the coronavirus, we could have said we are the first to have this adaptive radiation therapy platform. But either way, we're still a handful and certainly the first in Southern California, at least I believe. And so I just want to give you a couple quick examples. So on the left is a prostate radiation plan. This is again the image where you're laying on your back and your bladder's in the front, your rectum's in the back, and your prostate's sitting right in here. Again, a nice empty rectum on the planning scan. But then when they come in for treatment, the rectum is full, stool, gas, all these things. If we were to give the plan that we had developed on the left, you know, that radiation would be coming back here to all of this part of the rectum. Again, we don't want that. There's no reason that the radiation has to go there. We don't think there's tumor there. It's just because of changes in the anatomy. So the Ethos platform is able to rapidly redraw the target, change the plan to move it off of the rectum, move it off of the bladder, and dramatically reduce the radiation doses to the bladder and the rectum. Another big use of this, we often will be treating pelvic lymph nodes. So, you know, when the cancer spreads, it can spread to the lymph nodes on the side and the back of the pelvis. We're often limited by how much radiation we can give to this area because the bowel sits right in front of those lymph nodes and it moves around day to day. So we never know exactly where that bowel is going to be. So we'll often treat the prostate itself to something like 80 gray, for example, but we're limited to about 45 gray to these pelvic lymph nodes because we don't want to damage that bowel. But what's cool with Ethos is we can see where that bowel is on a given day. Like on the left, you can see this is what the radiation plan normally would have looked like because that's usually where the lymph nodes are. But in this case, a big loop of bowel drifted back right into the middle of that radiation field. And again, that bowel doesn't have any cancer. There's no reason we want to give radiation there. But in the past, we just were kind of stuck because you changed the plan. But not anymore. Now we can actually adjust it and say, well, there's no tumor there, so let's push the radiation away from the bowel and spare that bowel. So those are just two quick examples. And this is something that we're really excited about doing. We haven't got the machine. We've had some of the planning software, so we've been able to plan what the radiation techniques would look like and what the outcomes potentially would be like. But now that we're actually getting the machine and we're going to be able to start rolling it out and treating real patients with it and getting real outcomes, we're really excited to see what we can do for this. And you know, one of the first sites that we're going to roll this out for is prostate cancer, because it is one of those areas where there's a lot of organ motion and we can see the prostate and the bladder and the rectum relatively well. So we will be able to adjust these plans pretty quickly. But lots of other sites. Bladder cancer is another one that we're really excited about because the bladder is, again, is very hard to keep it in the same position every single day. So lots of really exciting applications to this. So hopefully, you know, maybe after the pandemic is over, I can come back and tell you all our success stories and how much better we're doing now. But this is just sort of a taster for now. So, all right. Thank you so much for having me, and I'll pass the microphone virtually to our next speaker.
So our last of our group is going to be Carl Rossi.
Go ahead, next slide, Tyler. Yeah, go. Yeah, so we're talking about technology that really is not all that old. From a historical perspective, radiation therapy came into being the very in the 19th century. So we have just over a century's worth of clinical experience with its use. Next slide. And I think it's also important to realize that irrespective of the type of radiation that we deliver, and you've heard about some very complementary technologies today, the fundamental target for radiation therapy is DNA. That's how we kill things with X-rays, how we kill things with protons. We're breaking DNA and we're relying upon creating enough breaks so that the cell cannot repair those breaks and then still survive. And we're also fortunate from a biologic standpoint that in general, malignant cells are somewhat less able to repair that injury. And that's the difference that we exploit with radiation treatment. And all of our technologies have really been designed to try to use physics, what we understand the best, at least for the moment, to exploit our ability to create DNA injury, hopefully in the target tissue. Next slide. Go ahead, thank you. So, I showed you a minute ago that this has been going on. We've had radiation, understood radiation since the latter part of the 19th century. It was very quickly used as a cancer treatment because of some observations that people made regarding the effects of radiation on the skin. But radiation is also, a harmful thing. We can use it to kill cancer, and it causes cancer. It causes all sorts of other injuries. This picture you see here is a monument I think it's in Hamburg, which lists on it a couple hundred physicians and physicists who died from the effects of radiotherapy in what we like to call the early days, although these things can still happen today. But we must always keep that in mind with radiation treatment, that we are constantly walking a relatively fine line between doing enough to kill the bad stuff and not cause irreparable harm to the good stuff. And you've heard some nice presentations this morning on ways that we're trying to further improve that difference and to keep from hurting people. Next slide. Okay. Some very basic tenets of all radiation therapy. Dr. Mundt touched on this. For one thing, you'll often hear physicians and other people say, well, these cells are radiation resistant. That's a relative term. It's all a question of the dose that you deliver. And in prostate cancer, like other cancers, we found that higher doses have equated to a better chance of cure. Another area that we consider in radiation therapy is this principle called ALARA, which is an acronym that stands for as low as reasonably achievable. In effect, we do not know, although this is controversial, if there is a threshold dose below which radiation injury doesn't occur. And this also has driven, this realization has driven all of our technologies. Why do we use protons? Why do we use implants? Why do we do IMRT and VMAT? Because we're constantly trying to use these technologies to minimize the radiation that we give to healthy tissue. Next slide. Okay. You've heard about a lot of advances in radiation therapy technology, and as I alluded to a minute ago, they've all been primarily based upon our knowledge of the physics of radiation treatment and how we can use that physics to improve the specificity of our treatment. That's true of everything: IMRT, protons, brachytherapy, radioimmunotherapy. They're all based on using physics to help improve specificity. This is also because we lack, although we're gaining it, understanding of the basic radiation biology. We know much more about the physics of our treatment than the biology of our treatment, although fortunately that is changing. And you saw what Dr. Sharabi presented earlier in some of the ways that we're trying to use the biology of radiotherapy to enhance the immune response to malignancy. Next slide. Okay. We've heard about IMRT. It's just one of the many ways in which we can deliver radiation therapy. It is probably the most advanced form of X-ray therapy that is available now. And it came into being because of the physics. We didn't do randomized trials X, Y, and Z to prove that it was better. We incorporated it into our radiation therapy armamentarium because the physics were obviously better than its predecessors. And this is the pathway that we have followed in radiation therapy really for the last 100 years. Next slide. Okay. And this is what you're able to do with an IMRT type treatment. You can pile dose into the target, very high dose, very tightly conformal dose, but you still end up, because you're using X-rays, giving dose to tissues away from the target. And while in many cases that's not a clinical issue, if we didn't have to do that, we wouldn't do that. And these technologies continue to evolve to keep us from having to do that. Next slide. So that has made IMRT, though, because it's available, the primary method of delivering radiation therapy in the clinical setting. Protons, as you're going to see here in a second, have some superior physics, but their availability has been far inferior, so their utility is therefore limited. And that's something we're working on in the proton world. We're working on making the machines smaller and cheaper, but that's still what limits what we can do with particle beam and proton therapy. Next slide. Okay. What's a proton? It's a subatomic particle. It's the most common particle in the universe. It has a mass and it has an electric charge, and those are the two things that determine its physical properties and make it different than X-rays. Next slide. You cannot, of course, have a proton talk without the Bragg peak. This is a fundamental, it's what makes protons different. In essence, what William Henry Bragg discovered back in 1903, 1904 is that when you shoot electrically charged subatomic particles into a medium, the maximal dose is at depth, and then the particle comes to a stop, and there isn't any dose beyond that point, which is different than the way X-rays work, which tend to propagate entirely through an individual, especially when we're using external beam X-rays. Next slide. I think it's nice that the Australians have finally started building, by the way, their first proton center. It's being constructed in Adelaide, which is where Professor Bragg did his work, and they have named it after him. It should be up and operational in about 18 to 24 months. Next slide. Robert Wilson, who was the founder of proton therapy, another physicist, he was the gentleman who wrote a paper in 1946 saying this would be an interesting way to treat cancer if we could only figure out how to stop those particles where we'd like. Next slide. Some background on him that I'm not going to go into in the interest of time, but if you like to learn more about him, just look at the Wikipedia entry on him. He was a total Renaissance man and somebody I had the opportunity to meet on a number of occasions. Just a fascinating, fantastic individual. Next slide. Okay. This is going back to the history of proton therapy, which was started in the mid-1950s at the Lawrence Berkeley lab using techniques that are thankfully well outmoded today. And you fast forward to the late 1980s, and which is when Loma Linda broke ground on their facility, which was the world's first medical proton center. Next slide. Okay. This is the way that up until recently most proton centers have been constructed. Dr. Mundt showed you a picture of one of the gantries, and you can see the scale and size of it. Our facility in San Diego has 5 treatment rooms served by 1 cyclotron. Very big, bulky, expensive to build, expensive to operate, expensive to maintain. Next slide. But now, thanks to technology advancements, which is what we see in all fields, medicine otherwise, you can create a single room version of the same facility that fits into a tennis court. And this is why we're finding more and more proton centers being constructed. Next slide. We also have changed the way we deliver treatment, and we now use electromagnetically scanned beams, which give us far more specificity and adaptability in our treatment plans than we had in the past. Next slide. Currently, there's 37 operational centers in the United States. There's about another 50 or 60 around the world. The majority of the new facilities that are being planned in the US are much smaller. They're the 1 to 2 room centers, which are still expensive, but far less expensive than what we have now. And I think if proton therapy has a future, and I think it does, it's going to be going in that direction toward much smaller centers that you can have in a community setting and not just relegated to an academic facility. Next slide. Okay, that's a map of where they all are. The majority are in the Midwest and East. Next slide. Okay, go ahead. Next slide, Tyler, thank you. This has been touched on a lot today. We have these fantastic weapons to hit things with high doses of radiation, but you want to know where the target is. And we're getting better and better at targeting because multimodality imaging, CT, MR, PET, keeps improving in a synergistic fashion. Next slide. If you do CT only, you get a decent picture, but it doesn't the whole picture. Next slide. Yeah. With MRI, you can get much better definition of the prostate. You can see where the disease may be, its bulkiest state, and you can see the contours of the gland to a much greater degree. Next slide. Okay, that arrow is pointing at an area which is showing up both with T2 weighting with apparent diffusion. Go ahead, next slide. Next slide, please. This is an example of a patient I was planning yesterday where we were able to integrate his gallium-68 PSMA PET to define lymph nodes that we want to boost. Another exciting imaging technology which is now becoming more available clinically. Next slide. The typical proton plan looks very similar in many respects to an X-ray plan. The difference is that the low dose bath is considerably less because of the difference in the physics. Next slide. That's looking at the same patient sliced laterally, and that's dosed from 100% down to 10%. So you can see that there's a lot of normal tissue which is just not being treated. Again, that's the physics of the beam coming into play. Next slide. Okay. And also you find with proton plans that the disparity in radiation dose between normal tissue becomes greater between protons and X-rays as the fields become larger and more complex in their shape. What you have on the left is treating prostate and pelvic lymph nodes with protons versus using very advanced X-ray therapy. They both do an excellent job of getting dose on target, but you do spill a lot more dose than normal tissue with X-rays to cover that complex shape. Next slide. Okay, what I want to concentrate here in the last few minutes is recently published data. I mean, that's what everybody wants to know about. This is from the University of Florida, which was doing a cohort study between proton patients that they treated and patients they treated at the same institution with IMRT. I mean, it goes back to nearly 20 years ago. Used fairly standard radiation doses. Median follow-up was pretty good. And ADT was used in both groups as we typically do now, depending on the disease status. Next slide. First of all, when they looked at the overall survival, there was no difference between that for the patients who were above a certain age. However, when they looked at the patients who were younger than 75 and the low-risk patients, they did see that there was about a 5% difference in overall survival between the groups that was statistically significant. With the intermediate risk patients, the trend was there right on the verge of significance, and the high risk patients, there was no difference. So that's, this is not the sine qua non. I mean, it's just indication that there may be some groups that are benefited more by one form of radiotherapy than another. Next slide. Okay. In terms of toxicity, they did see some differences there as well. That the proton patients in this study did receive a somewhat higher radiation dose, but the incidence of what we call grade 3 or significant gastrointestinal and/or GU toxicity was considerably lower in the proton patients versus those who were receiving treatment with X-rays. So their conclusion was that for some subgroups, there was an improvement in freedom from biochemical recurrence. Despite the fact that there were some biases in the IMRT patients that they used longer doses of ADT that you would expect could increase the freedom from relapse in that group. And there was some differences or at least decreases in toxicity favoring protons despite a higher median dose. Next slide. Northwestern has had protons now for several years, and they did what we all kind of sometimes like and sometimes frown about, a big Medicare database study. They were trying to match up proton patients to IMRT patients that they had treated while they were treated in the SEER database. Again, between 2006 2012, there were patients who received either X-rays or protons. They were no mixed treatments. They again saw the same hint that the University of Florida folks saw, and that there may have been a little bit of a difference in overall survival favoring the proton patients. And interestingly, the reason for that was not because of disease progression between the groups. It was because of the second malignancy rate, where there was a difference between the groups, where they saw at 5-year rate of 6% second malignancies in the proton patients versus just over 10% in patients receiving IMRT. And these were primarily pelvic malignancies and leukemias, probably due to the decrease in the total amount of tissue that received radiation between the modalities. And we're going to talk more on this in a minute as well. Next slide. Okay. This is a registry trial that involves about 20-odd proton institutions around the country, which has been looking at patients who received radiation, either protons or IMRT, for advanced prostate cancer. Really just looking at toxicity. This is short follow-up, but we were primarily interested to see if we could decrease the GI toxicity by treating the pelvis with protons versus X-rays. And when we compared the proton toxicity rates to published data in IMRT, we did see that it was we did decrease that GI toxicity. Again, not randomized. It was it's just a comparison, but it gives some sense that if you can decrease the amount of radiation to the normal pelvic tissues, you can reduce the harm that you cause. Next slide. Okay, and this was some data which was published earlier this year in Cancer from the University of Pennsylvania, which was a very in-depth study looking at the risk of radiation-induced malignancies between 3D conformal X-ray therapy, which was the standard of the 90s, IMRT, or proton beam treatment. Next slide. So this used the National Cancer Database to get their patient information. It looked at some 9 million cases between 2004 2019, just under 500,000 of whom had received either 3D conformal, IMRT, or proton therapy for non-metastatic disease, and where there was a minimum 2-year follow-up. Now, the vast majority of these were X-ray patients because of the huge disparity in the number of people getting X-ray therapy versus protons. Protons are still a very scarce modality. The median follow-up was just over 5 years, but when you look at the number of patients involved, they talk about 2.5 million person years, which is a pretty impressive figure. And what they were looking at was what's the incidence of second cancer. Next slide. So first of all, interestingly to me, they didn't find any difference in the second cancer rates between 3D conformal and IMRT, which was something that I thought was a bit of a surprise because IMRT is like a higher dose bath. They did say that, however, when you look at the incidence of second cancers between proton treatment and either 3D CRT, excuse me, or IMRT, it was about 1/3 the number of second cancers that were seen, and they went and did a lot of statistical analysis of this. So they said, we see this difference, this 1/3 the number of second cancers in all age groups, and really in all disease sites except for lung cancer. And they even did, they looked at it whether or not if you excluded certain patient populations, there was a difference, and the answer was no. So fairly strong data suggesting that a decrease in second cancers between proton treatment and treatment with various forms of X-ray therapy. Again, probably due to the difference in the total amount of tissue being radiated. Next slide. And they looked at it again with all tumor categories, and they found that this difference existed in everything except for lung cancer. And even when they excluded, took prostate out of the equation, they still saw that this difference existed, favoring a decreased second cancer rate in patients receiving proton therapy for a variety of malignancies. Is this potentially important? Of course. Among other things, we're doing a better job of curing people, or at least putting their disease into long remission. So when that happens, you start to worry more and more about the long-term effects of your therapy. We've seen this classically in pediatric patients treated with radiation and Hodgkin's patients, but we're seeing more and more adults who are surviving their disease, and you'd hate to have them succumb to a treatment-related complication years later while their primary tumor was still under control. Next slide. So this is just their conclusions, and they were fairly consistent with what some mathematical modeling studies had shown, and with some other published data. Is this the answer to the question? No, we're going to be studying this for a long time, but it does support the idea that treating less normal tissue is going to be beneficial to the patient, which we've known empirically for many years, but we're seeing more and more, clinical data that buttresses that fact. Next slide. Okay, so quick conclusions. At first, I think it's fair to say that proton therapy, because of the availability of equipment, is no longer boutique, thankfully. We're finding it's much more available now than it was even 5 to 10 years ago. And this just follows the same trend of all new radiation therapy technologies when they get adapted. We are still learning the ultimate way to use this, as we are with radiation, X-ray therapy. And most importantly, we need to get to the point where the cost to the person who's paying for this treatment is no different, whatever modality that the radiation oncologist uses, so that we can do this, in a totally agnostic, at least financially agnostic way. And that's where we're getting to, but we're still not there yet. Next slide. And we do have published data showing that we can reduce toxicity, in especially GI toxicity, less bone marrow suppression. I didn't touch on it, but there are papers on less testosterone suppression and what I mentioned earlier, lower incidence of radiation-induced second cancers. Next slide. Well, thankfully, thank you for putting up with my technical issues and forbearance. And Tyler, thank you very much for doing what you did to get this presentation going. Thank you.
Well, thanks, Carl. And why don't we do more questions and answer? Why don't we look at some from the Q&A box?
Go ahead.
The top one from Lyle, please explain the use of a helical coil or rectal rod for an MP-MRI, which is better and why. So I think you're talking about an endorectal coil, which is where you put a coil in the rectum for the MRI. That used to be really common. And part of the reason was because the scanners, almost all the reasons, because the scanners weren't as good. On a modern scanner, it's no longer necessary. So there are still some places doing it, but we don't do it at UCSD ever, the endorectal coil. We mostly do scans at 3 Tesla instead of 1.5. It's very well accepted that with 3 Tesla, you don't need an endorectal coil. And if you set up your protocol as well, it's not necessary. So it's uncomfortable and unnecessary. If you're going somewhere where they're insisting you get it, maybe you come see us and we'll take care of that.
Tyler, do you mind sort of looking at the other questions?
Sure. So that one I answered. Let's see the next one. Larry Weaver. Can proton treatment of prostate cancer bone lesions cause pain that was not present before treatment? Oh, Dr. Sharabi's already answering that one. Typing it says.
I'm in there. Yeah, so that question, can radiation cause some pain? There's a phenomenon called pain flare. So usually radiation is highly effective for treating pain, and that's palliatively why we deliver it for bone pain. But in some patients, it can cause a little bit of a temporary flare before it dies down. And that percentage may be around 25, 30%. Usually it's kind of a little spike and then dies down. But in majority of cases, radiation will help, the vast majority will help with pain control.
Next question is from Woody, is asking about how soon to monitor PSA specifically for HDR brachytherapy. Is it too soon after 2 weeks? You can check PSA anytime. What counts as too soon? There's no harm in checking sooner, but it's not really reliable very soon after with radiation. And we expect that the PSA will continue to decline over even years. So there's no rush. And you're not going to do anything differently at 2 weeks, which is why I wouldn't order it. Guidelines are usually saying about 6 months. I check at 3 for the first time, just because that's when I see the patient back and it's nice to see what the trend is looking like. And then after that, 6 months, but there's no magic answer and you're really in for the long haul. It's how much is the PSA changing over time, months to years. It's different. The one time it's really different is after surgery. Then about a month after, even a few weeks after surgery, you can check, and that's meaningful. Yeah. So not too soon, no harm, but it won't give you a definitive answer.
I think after radiation, any PSA is never a one test tells you everything. So I've had patients like stay up all night before not sleeping because they're scared of their first PSA, but it's not like a pregnancy test, pregnant, not pregnant. It's what it is the first data point where we use to see what happens. So it's a hurry up and kind of wait thing. You get a point, and then 3 months later we get another point, and we then can start answering how are things working. So don't stay up all night worrying before a PSA or studying for a PSA testing.
And no matter what the result is, if it's concerning, you're just going to repeat it first anyway. So we don't even necessarily believe it the first time we see it anyway.
Yeah, specific to the brachy question, That soon after any procedure to the prostate, the PSA could easily be falsely elevated. So there's nothing wrong with checking the PSA if you really want to, but if the PSA is higher, I wouldn't worry about that necessarily, because often whenever you manipulate the prostate, PSA rises. So if you've had a catheterization or if you had even a prostate exam, the PSA can be falsely elevated. So that soon after a procedure, you can check it if you want to, it doesn't hurt. But if the PSA is elevated, I wouldn't worry about that at all. If it's lower, great. Like everyone else is mentioning, you really need to see multiple PSA tests over time. Just wanted to mention, don't be too worried if it's elevated, because the procedure can do that.
So this one is from Lyle. For a first-time diagnosis with a rising PSA, would you recommend multiparametric MRI or PSMA scan prior to and instead of a biopsy? So I assume that you're asking, Lyle, if we haven't had a biopsy yet, so it's not really a diagnosis yet, but the patient has a high PSA, and would you recommend imaging before the biopsy? And if that's the question, if I'm understanding correctly, then I would say the evidence for doing an MRI before the biopsy is very good. That's solid evidence, and that's now standard of care in Europe. It's pretty close to standard of care in the United States in terms of guidelines, but it takes time to roll things out, and there's different insurance and coverage and patterns and whatever. And there's also just, you know, who's in charge of ordering the test. So there may be some variation in opinion, but personally, I think the evidence is very strong. You get an MRI, it doesn't mean that you can skip biopsy necessarily, but it might. And even if it doesn't mean you skip the biopsy, it shows them where to point the needles. So I like to think if you're going to put 12 needles in me, you better make sure at least one of them is heading in the right spot. And you do that with an MRI. And then with the PSMA scan, that's a different question. PSMA prior to diagnosis is not going to be covered by insurance. It's only been recently approved for FDA anyway, so you'd have to find some kind of a research study where they're experimenting with that. And I'll tell you that I'm skeptical that PSMA is going to be better than multiparametric MRI for that. So the future for future investigation, right now, standard of care is definitely MRI.
There is actually one question that's open at the moment to Dr. Rose. What dose of daily radiation is involved for ethos adaptive technique?
Yeah, the nice thing is that you can do whatever you want. So this could be used, can everyone hear me?
Yeah.
Okay. So this could be used for conventional fractionation, 2 gray per day, sort of the standard dosing for the 7 or 8 weeks. But it could also be used all the way down to SBRT. So you're giving very high dose, 7 or 8 gray per day for a total of 5 days. It can be done either way.
So many patients are always curious how some of these imaging techniques, how well they work at very low PSAs. And so with the MSI MRI technique, how high does your PSA need to be, especially if it's after radical prostatectomy?
Yeah, it's an important question, and we don't have a great answer for that yet. Everybody wants to push after prostatectomy for really low PSAs and to be able to find disease. And there is going to be a limit to what you can see. The PSA is somewhat correlated with the size of tumor, and you can't see anything smaller than a voxel. Voxels are, a few millimeters by a few millimeters. So realistically, I think that less than 0.5, it's really going to be hit or miss. Above 0.5, we have some decent hope. Whether PSMA is more sensitive than RSI is an open question that we're studying in collaboration with UCSF. And we don't really know the answer. I mean, PSMA is the most sensitive so far, with lots of caveats, and you can find stuff less than 0.5 with PSMA, but even then it gets dicey. So
Gotcha.
Yeah.
There was a question from someone regarding Foundation 1 liquid biopsy. These are kind of new genetic tests and genetic profiling that people can obtain, and these are FDA approved in the blood, and they can help to identify alterations or potential targets for new drugs or therapies. And so we certainly have that available. Actually, UCSD has one of the largest databases, partnering with Foundation One and Garden to look at that. So specifically of interest, the medical oncologist probably best at UCSD would be Raina McKay for a prostate cancer to help identify new drugs and targets. Raina McKay would be the best. Also, Sandeep Patel is very good also in combinations with immunotherapy. So, we did talk a lot about radiation, but there's many additional clinical trials using immunotherapy with other targeted drugs. So cabozantinib. We also have a PSMA bispecific antibody, a trial that's going forward that actually targets the PSMA, and also a CAR T-cell, a T-cell therapy targeting PSMA, which is also another trial. So Raina McKay could help with those.
So just to address maybe,
Go ahead.
Okay, great. So to address Margaret's question, Margaret asked a good question about whether there's radiation dose associated with the pre-treatment scans that we would be doing for the Ethos platform. And the answer is there's no actual additional radiation from that. So every day before the treatment, we do a mini scan called a cone beam CT scan that has a tiny, tiny little bit of radiation associated with that, but it's nothing like a full diagnostic CT level of radiation. And it also is much, much smaller than the actual radiation treatment that we're going to give. So it really doesn't add any, doing the Ethos platform and adaptive radiation doesn't really add any additional radiation to what you were going to get anyway for the standard treatment plan. Great question.
I'm going through the list here typing, but there have been now 2 in a row that are on imaging. So I'll say that I didn't talk about it in my talk, but we do have an open clinical trial also looking at that same MRI technique, RSI, for the whole body. So the one I was talking about today is the one we just opened. That's for localized patients who haven't been treated yet. But if you have metastatic disease or suspected metastatic disease, like a pretty high PSA after prostatectomy, and we find a metastasis, then you would be eligible for this other trial where we would do a whole body MRI, and then we would treat you, and then we would do that again afterwards. So that's something that you can, if you're interested, you can email that same email address that I put on my slides. And I've been putting in the response here as well, so you can check the Q&A, but that's another option for patients at UCSD.
Great. How well do these, especially the clinical trials, how well do they translate to other types of cancer? Are you able to pick up other types of cancer besides just prostate?
Yeah, so the imaging with MRI and the diffusion is going to work for basically any hypercellular tumor. So almost any solid tumor, it will probably work. And we have good data for several. We have good data for breast cancer, that it's actually an improvement over standard MRI for breast cancer. And cervical cancer is looking promising. We have a study opening this year for that. It's been funded. A little bit of data in rectal cancer. And we also have a study that's open in head and neck cancer. So it works for all things, and that's good. Whereas something like PSMA is supposed to be specific for prostate. It's not perfectly specific for prostate, but it's supposed to be. So that gives it a little bit of an edge, perhaps at the very low PSA range. But it means that if you stop expressing a lot of PSMA, for example, with a very advanced dedifferentiated prostate cancer, or if you have some other kind of cancer, it won't work. So they may afford opportunities for complementary information. And for that matter, it's also been used, though we're not doing that actively now, but we've used, we did collaborate with a company one time for a whole body diffusion MRI for screening. It was just kind of a outlandish thing that was for people who had a lot of money on their hands. And but for what it's worth, we did find lots of different kinds of cancers. If you scan enough people, you'll find stuff. So,
sure. I seem to recall a number of years ago, our CEO of a prior company I worked at getting one of those scans.
Yeah. No, I mean, it's an interesting project, interesting data, but definitely not ready for prime time.
Thank you, doctors, for so much of your time today. As you saw, there was one comment that came in that this was one member's very first meeting, and they were blown away with how informative it was and useful. You guys really are helping out a lot of people, not just in your own practices, but by joining us here today. And so without any other questions, I'll say thanks again. And we're looking forward to having you on yet again. So take care, everyone. Thanks.
Thank
Thank
you,
you.
doctors.
Thank you.
Great presentation.
Yes, wonderful, wonderful presentations. Learned a lot. Thank
Stay
you.
safe.
Thank you.
Thanks, everybody.